Welcome everyone to our journal club for 2021. This is our third journal club today, and we welcome all the programs with us. I have Dr. Trojan with me, co-hosting today as we go through another article regarding MSK ultrasound. Now, during this, we're still focusing on some key units of ultrasound, particularly Unit 1 as you're working through your fellowship. And we're going to be looking at interventional ultrasound and looking at some older articles and a more recent article on what the evidence is for using ultrasound in injections. And welcome to all the programs that we have here, and I'll continue to update this list. This week's Journal Club is brought to you by Atlantic Sports Health Fellowship Program, and we have 3 fellows per year and located in Morristown, and do a lot of coverage with the Jets and Seton Hall, and our fellow who's out there with the Jets out in Green Bay now will be presenting shortly. The articles we will be discussing will be the AMSSM position statement on interventional musculoskeletal ultrasound in sports medicine. I know this article is a bit old, but it still is very, very pertinent and is kind of standard reading for fellows starting their fellowship to read about interventional ultrasound. I also put down the AIUM practice parameter for selected ultrasound guided procedures. Again, a bit outdated, but some things in ultrasound don't change. And this is a classic article going over some common techniques that you need to be familiar with on that. So our presenter today, who I introduced and I've gotten a chance to know as he started his year off, he's from Atlantic Sports Health, did his residency out at Stanford, and has been a joy to work with so far on there. And he's going to be telling us a bit about him and then presenting this article on the AMSSM position statement on interventional MSK ultrasound in sports medicine. So I'm going to turn it over to Justin to go over this article, and then we'll go over a brief lecture.
Good morning, everyone. My name is Justin. I am one of the current sports medicine fellows at Atlantic Health. So I'm going to be presenting the article that Dr. Monaco mentioned. It would be the AMSSM position statement for interventional musculoskeletal ultrasound, and then also the 2 supplemental readings that Dr. Monaco initially sent out. One was the up-to-date article, and then the other one was the one that he just mentioned, the Association for Medical Ultrasound. The outline for my talk will be just a brief introduction about the article, the literature review that was done, the major findings, and then also the conclusions, including how to use it in the practice, and then any questions at the end of it. So a little background about the article. So for the past decade now, and again, this article is a little outdated, so it's a little bit more than that. Both diagnostic and interventional ultrasound has significantly increased. The majority of this increase has been seen by non-radiologists, specifically, sports medicine type physicians in the sports medicine field. This increase is due to many reasons, including equipment costs, increased educational opportunities, expanded research, patient safety initiatives, technological advances leading to high resolution images, among many more, in which they did not mention. Sports medicine, ultrasound commonly used to guide interventions such as aspirations, diagnostic ultrasounds, therapeutic injections, tenotomies, releases, and then hydrodissections, as you all know. And then the purpose of this position statement was kind of a bunch of different things. The majority of it was to evaluate accuracy, efficacy, and cost effectiveness on ultrasound guided injections in major, intermediate, and small joints as well as soft tissues. So kind of going into the article itself, it was a critical review article, and they looked at a bunch of existing literature. The authors searched the Cochrane database of systematic reviews in PubMed as well. They searched keywords, including injection, accuracy, efficacy, ultrasound fluoroscopy, joint, and arthrography. And then based on their findings, they also looked at the references for each one of these articles for further studies. After they found a lot of articles, they then study the accuracy, efficacy, or cost effectiveness of the ultrasound guided or landmark guided injections. They included all of these in their analysis for the position statement. The literature review, a little bit more about it. Level of evidence for each article was ranked according to the Journal of Bone and Joint Surgery. For accuracy studies, the level of evidence was determined based on 5 levels, anywhere from level 1, which was injections performed on live participants with accuracy confirmed using gold standard diagnostic imaging, all the way up to level 5, which was case study or expert opinion. And the definition of accuracy that they used was being able to place the injectant or needle tip in the intended structure. And then it was further divided into subcategories based on the joint that they were looking at, whether it be major joints, intermediate joints, small joints, multiple joints, or soft tissues. And the major findings from this article was that for the major joints that they looked at, ultrasound guided injections other than SI joints are more accurate than landmark guided injections. And the only reason that SI joint was excluded from this was because there was not enough research that was found. And so they left the position statement open, saying that they need more research to determine the accuracy of ultrasound guided versus landmark guided SI joint injections. For intermediate joints, they found that, again, ultrasound guided injections are more accurate than landmark guided injections, although landmark guided for the elbow and ST joints were relatively more accurate. For small joints, again, ultrasound guided injections were more accurate than landmark guided injections. For soft tissues, ultrasound guided injections into the tendon sheets, peritendinous regions, deep gluteal muscles, including the piriformis and obturator internus, the pes anserinus bursa, and the sinus tarsi are all more accurate than landmark guided injections. For the multiple joint injections that they looked at, again, ultrasound guided injections into inflamed or painful joints are more accurate, less painful, more efficacious, and less expensive than landmark guided injections. So overall, they looked at the 3 things: the accuracy, the efficacy, and the cost effectiveness. And based on their evidence, they gave it their own sort recommendation. So for accuracy, ultrasound guided injections are more accurate than landmark guided injections. They gave that a sort A recommendation. For efficacy, again, they said the same thing. Ultrasound guided injections are more efficacious than landmark guided injections. However, they gave that a sort B. And then for cost effectiveness, the same thing. Ultrasound guided injections were more cost effective than landmark guided injections, again, with a sort B recommendation. So the strongest evidence coming from this article was that the accuracy of ultrasound guided injections was more than the landmark guided injections. So conclusions from this article: strong evidence that ultrasound guided injections more accurate than landmark guided injections. Again, for some of the joints, including the SI joint, more research is necessary just because they didn't have any included in their review. There's moderate evidence indicating ultrasound guided injections are more efficacious and cost effective than landmark guided injections, with a sort B recommendations for both of those. And then in the author's opinion, many of the new procedures coming out require ultrasound guidance in order to perform the procedure safely and effective. And again, that's a sort C level recommendation because they didn't actually look into this This is more of just the opinion from the author. And then a little impact on clinical practice. So when you're doing an injection or performing any soft tissue injections, you should consider ultrasound guidance rather than landmark guidance. And then consider ultrasound guidance when perform procedures that should utilize guidance, such as percutaneous needle tenotomies or lavage and aspiration of calcific deposits. And that is it. So if there's any, I don't know if there's any questions, but if there's any questions.
All right, thank you for that great overview on that. I'm going to highlight some of the key factors on that, and also want to let people know that there are some very good recent articles out of Europe looking at each joint where it goes through the evidence on using ultrasound versus not, when it's indicated, when it's not. And I'll link to those either in another email or get them out for people who are interested. Just let me know. And those are more recent, and they go through the evidence why and the why you should use ultrasound or why not, and when it's supported on each joint. So we'll link to those, but those are separated by each joint, and a lot too much to go through for this current journal club, but I will link to those, and they're definitely worth reading for the group there. Let me just share my screen, and I'll turn it over to Tom for a minute to talk about his thoughts on the article.
All right. You know, I think the article points out a couple things that are important. You know, the ability to place a needle more accurately can be helpful for aspiration and reducing patient dissatisfaction. You know, sometimes I think it makes no difference because some of the things that we do with corticosteroids are going to be the same either way, because it's not, you know, the corticosteroids aren't necessarily the answer for the problem, but we inject them often anyhow. And so I think that's important when you're looking at the studies to see which is effectiveness. So how effective is injecting the joint with ultrasound outcome-wise versus corticosteroid, you know, versus landmark based, because the treatment may not have much of a difference if you place it in the right place or you just place it around the joint itself. So I think that makes a difference. And I don't know from you, Rob, whether or not you've seen a number of papers out there that look at the, I personally have not, PRP landmark based versus anatomic based.
Well, I think we'll go through with that, and it's very important, particularly on certain types of injections where ultrasound really should be required across the board on that. I've launched a poll, so you guys can take a look at that, and we'll go over those questions and go through. I'm going to run through some key important topics on this that we're going to go through on that and with everyone. You all can see my screen, right? Good. Tom, if you can handle some of the question and answers that come up there, there's some in the Q&A. We'll take a look at that as well as they come up or in the chat on that.
Right now, they're coming up in the chat is where people are from.
Okay, great.
So,
all right. So I want to review some of the common indications for ultrasound injections and talk about some of the common principles that were talked about in the second article on that. Really, ultrasound is a key for three important things. It allows real-time visualization of your needle. It gives us direct guidance versus indirect, and it can target very specific structures on that. The accuracy across the board in almost every area shows ultrasound is significantly better than landmark guided, particularly in the inexperienced person. As people get more experience, it gets much better on that. But there are 6 key advantages of ultrasound guided. It's especially when the inject date is really the main thing at your therapeutic target. So like PRP or one dose visco, ultrasound shows very good efficacy versus landmark. Two, when you need some more diagnostic information about what's going on, it gives you a better indication of secondary structures around the pathology that you may need to evaluate on that. Three, there's less damage going on with ultrasound at the target, so you don't need to use as much of the your injectate. So there's less injectate as well, and less amount of moving the needle around to get into tissue. So there's less damage to the target and the surrounding tissues. And then number 5 is this patient friendly. The studies have shown that there's less pain with ultrasound guided. Patients tend to have higher, better feedback after ultrasound guided versus not. And it seems to be a better situation for the patients when you're doing ultrasound guided. And lastly, number 6, for advanced procedures, ultrasound guided is needed. And there's many, many advanced procedures which are coming or you're going to see this year, simple ones such as a pulley release or a first compartment release versus carpal tunnel releases versus more detailed tendon work such as fenestration, barbotage, stripping or breezement, compartment releases. All these are new things which have to be ultrasound guided. So all these advanced treatments, which are going to become much more commonplace, really need, absolutely need guidance to do, and it cannot be done blindly on that. And also there's going to be new tools coming out that you're going to see, new needles, new devices such as wires, and new instruments that will help with these procedures as you go through your career. So learning the skills of ultrasound is really critical regarding this on that. Now, there is some negatives with ultrasound. It is more costly, does require some training, but all this has really dropped as costs have come down, and the learning curve has gotten much less steep as people are learning this earlier on in their careers. It does add additional time to your visits, and there may be, you know, a question whether it really makes a huge difference in the end. So for some things, such as a simple knee aspiration, etc. But the positives far outweigh any of the negatives on this. Many of us don't do fluoro, but if you do have colleagues that do it, fluoro versus ultrasound, unless you're talking about the spine, and even there it's starting to change, ultrasound is going to be the preferred way for almost all soft tissue injections, non-spine, because of the reasons we outlined on that. So your indications for ultrasound are important, not just for your procedure, but also for when you're doing billing. So you have to really document that this helps you assess the anatomy, understand the pathology and different variations of the pathology, help you do procedures, collect fluid, etc. And certainly should be done in high-risk things such as people that may be on anticoagulants or in areas where you're dealing with deeper joints where it's hard to reach without guidance, or you're dealing with areas around neurovascular structures on that. In some cases, you want to avoid radiation completely and not do fluoro. And it's also indicated for any of these newer procedures we talked about. Anything, particularly where you're doing biologics, should always be ultrasound guided on this. And it can be indicated in people that have had failed non-guided injections. So you may see someone coming in and didn't respond to a steroid that was blinded, and ultrasound is indicated if you're doing a second corticosteroid injection in an area. And then some people are very sensitive to pain. It can be indicated in those people that have problems with pain modulation. Contraindications are very few. The biggest one being recognizing your limits. If you don't have a good machine and appropriate training, you shouldn't be doing ultrasound guided just because you have the machine. You need to make sure you understand that. And general procedure contraindications apply as well on this. If you don't know what you're seeing and there's an unexpected mass or lesion, or you're not sure, you shouldn't be doing an ultrasound procedure on that until you know exactly what it is on that. So if you have those cases, get an MRI first, or have someone more experienced look at it so you know exactly what's on the screen before you do your injections on this. I can't tell you enough about confidence. There's certifications and training which you're all going through now on this, but you need to have key training, and you need to be efficient with your equipment. The biggest problem we see is people say, oh, I watched that once, I can do that. Ultrasound can be humbling. Make sure you're comfortable with your procedures. And just because you have an ultrasound machine doesn't mean you can just do the procedure on that. So make sure your diagnostic skill needs to match the complexity of the procedure on there, and that you're prepared to deal with complications, and that you have appropriate backup, particularly for doing advanced procedures on that. So when you do ultrasound, there is a big learning curve, and it's important that you keep your general principles that we talked about and that you're learning about this year, and make sure you understand all your anatomy. As you go through your general procedures, it's really important that you follow certain things and have good ergonomics, follow certain procedural steps, use sterility, and have good techniques, and document appropriately on that. Your room ergonomics are important to have with ultrasound, particularly when you're doing more complex procedures. We like to have a table that can either move up and down, or a screen that you can move so it's set up so you can easily look at the machine and target. For us, we usually have 2 screens, so we can easily do things and work on without kind of moving the patient all over or flipping them around. It allows us to get the appropriate angles on some things. Consider the lighting in your room. Make sure you have good enough lighting on that, and really consider the pluses and minuses of the injection positions on there, with patient lying being preferred for most. And make sure when you do a lot of these injections that you're comfortable and in good position, particularly with your head and eyes or hand coordination, so it can work and you're seeing the screen directly in front of you on that. So just some examples of different things. We like to use a lot of rolls and a lot of towels and positioning, particularly on certain injections, to keep the patient comfortable, or have a table that adjusts on that. Follow your standard procedures that you do with any injection, but important with ultrasound, in kind of going through a set steps on each time on there, where we identify the patient, get your presets into the machine on that, determine the best position, confirm the pathology first with ultrasound, and mark the area of your approach. Use your Doppler so you know your neurovascular problems that might exist in the area. Determine the best image acquisition or probe that you need, and determine the appropriate size needle or type of needle. And then mark the area so you know your approach. Then sterilize the area and get set up for your procedure on that. As I mentioned before, the lying position is the best position for you to be in for the majority of these conditions. Always important to optimize your image. We want to be able to see the needle coming in. So you want to give yourself a little bit of room to see the needle coming in, and have the target towards one end of the screen, so you can see the needle entering towards the target on that. Some of the machines have Doppler as well that you can put on at the time you do the injection, and consider that and really mapping out that vascular ahead of time. Marking the skin is a good technique that often can come in handy. We really want to try to stick with one injection path on that. So a lot of time I'll mark down where I'm going to go before I clean the area up. And this can be very helpful on this. As I put the probe back down, I'm not searching around for a target or moving off my target. When you do a lot of ultrasound, you're going to use a lot of different types of needles on there. So be familiar with your longer needles on there and your different types of needles, including echogenic needles, particularly for deeper structures on that. Also, we'll use specific types of needles for certain procedures, such as no core needles or larger gauge needles when we're doing it either releases or fenestrations. So you want to be familiar with these and have them handy in place. It's important to understand the needle length on this and to choose the appropriate needle size on that.
Rob, while you're doing that, I think the one thing that you mentioned there on the previous slide there that I think is useful for fellows is when you're doing a fenestration, often you'll have an anesthetic with you in the needle as you fenestrate. At least I do. And I make sure I try to remember to flush a little bit so that you don't get any of the tissue stuck in the 16 gauge, so that it clogs. And I think that I found to be helpful when I'm fenestrating.
Great. You guys see my whole screen? Because I get the poll keeps popping up on me, or you see the polls.
No, I see everything that you
All right,
have.
great. Sorry
The
about
poll,
that.
you just click on the poll and it pops out way.
Gotcha. So it's important to understand the needle length as well as you're dealing with things on this and understand. So a lot of times we'll do a measurement prior to our target, and you want to understand that you choose the appropriate needle size. Always better to have a little extra needle length than you do. The worst thing to do is get in there and you can't reach your target. Then you have to come back and use another needle on that. So always try to measure your target ahead of time, or understand appropriate needle length as you measure on the screen on that. It's always better to err on the side of having that slightly longer needle on that, or a larger needle, particularly in the beginning, makes it easier to see on that. The gauge can be important in terms of finding a needle in the beginners, but with good experience, you should be able to easily see a 25 gauge. And most injections are going to be done, with lower grade, smaller needle size on that for patient comfort, but larger gauge can needed for certain procedures on that. Remember, if you're aspirating, sometimes these hematomas, et cetera, you may need up to a 14 gauge. Now, sometimes we keep a lipoaspirate needle around for that, and be familiar with these. Many people are not used to using them, and they're good to have around for more difficult procedures on that. Spinal needles versus hypodermics. Spinal needle can be helpful because it has a longer bevel and it's a little bit more steerable. So some people prefer it for deeper injections on that, and it gives you a little bit more control of the needle, particularly if you keep the insert in on that, and allows us to do a little bit more direction for deeper injections. But with experience, you can get by with either one, but many people prefer spinal needles for deep injections on that. Make sure you have appropriate supplies on this. We use a lot of tubing with injections, so it frees up an extra hand, so you're not shifting your hand off of to the plunger to the syringe. And on more challenging procedures where you're close to structures, you don't have to move if you have tubing hooked up. So use tubing to kind of help you with your procedures, to have someone help you inject by injecting through the tubing, so you can just work on the needle. Also, using a needle holder to help change can be helpful, so there's no movement of the needle when you switch out your syringes. On that is another option to use that you want to get familiar with on that. Sterility is important, and you need to make sure you follow your standards with your institution on that. Make sure you clean the probe and the cord ahead of times. There's some debate on using probe covers for every injection on that, and this varies throughout the country on that. But no matter what, you want to clean the probe and clean the patient with preferable chlorhexidine on that. Give that a little chance to set into work on that. Don't just wipe and go. It takes a little bit of time on that, and make sure you're using a sterile technique. For most joint injections, it's full sterile techniques, particularly if the needle is going anywhere near the gel, or it has a chance to be anywhere in a site where you can have contamination on that. So there's a wide variety of probe covers on there. Some people use simple Tegaderm, sterile gloves, true probe covers, etc. You can improvise on this. I would say majority of my injections are not done with a probe cover, but for cases where they have either joint replacement or other things where the potential infection and sterility is done, but we'll do a wide field of cleaning the area and cleaning the probe ahead of time, and make sure my needle path is nowhere near the sterile gel or the probe on that, unless if it is, then I need to use a sterile probe cover on that.
I'll just add, I'm one who always puts Tegaderm on the probe so that so that just in case, to make sure there's no cross contamination with the person in the probe when I'm doing any injection.
And that's very commonly done. And I think,
Yeah, I'm not saying one way or the other, Rob. Yeah, just
absolutely. I think you have to look at your institution's policies and what you can do on that. And I think that is standard on that. Sterile gel is indicated for all the injections on that, though you can use chlorhexidine itself as a kind of a wet barrier to help you with scanning. And but it dries fairly quickly on that. Some people in the past use betadine gel. Takes a little longer for sterility, a bit more expensive, and stains the area. So most people use just straight sterile gel, individualized packs on this. So as Tom mentioned, all joint injections should be sterile and follow the standardized techniques that we outline. Alcohol and betadine at the site are insufficient. So follow your institutional regulations on that. I do not use for my simple knee injections, probe covers, et cetera. I'm pretty far away on my approach, but other joint injections, we use probe covers, et cetera. It's important, a few other factors when you're doing a lot of ultrasound guided injections that you work with your staff on. Make sure when you're drawing up substances to inject that you have no air in it. Any air within there will degrade your picture and cause a lot of shadowing and artifact, which can easily ruin an injection. So make sure you get rid of all air within your syringes ahead of time. Using an example here, just a needle coming in. If air comes in, you can see air has ruined this picture and makes it a lot harder to see on that. So it can ruin a injection very quickly, and it takes time to dissipate. And oftentimes you'll need to go a different approach. So make sure there's no air within the syringe on that to help you out. Local anesthetics is beyond the scope of this, but ropivacaine has the best safety profile and is preferred, but it is fairly costly to use when lidocaine is kind of your standard there, and bupivacaine has the poorest safety profile on that. Be aware about the onsets of time when you're doing your injections on that. And again, this is standard guided versus non-guided as well. Most institutions require a procedure timeout, so it's good to get in this habit and doing that. I'm going to spend a brief minute on just needle guidance and make sure we're all familiar with that on that. So I'm going to play this video that you get familiar with.
Given that we are most interested in nerves imaged on short axis, we will now look at how the needle will be seen as it approaches nerves. With the out-of-plane needle approach, the needle starts in front of the plane of imaging and advances until it crosses the plane of imaging as an echogenic dot. With the in-plane needle approach, the needle is visualized on its long axis as it advances within the scan plane. Now let's move on to show some of the common challenges with visualizing the block needle sonographically. Block needles are specular reflectors, meaning they reflect sound back to the receiver over a narrow angle. As the angle between the transducer and needle increases, less sound is reflected back to the receiver, and the signal becomes weaker. We can also see that this is true for sound reflected off the sides of the needle shaft. With the short axis out-of-plane approach, the needle will be seen best when the tip is within the plane of imaging. The shaft gives a signal that may be no stronger than surrounding structures. Generally, tissue displacement is transmitted far enough along tissue planes for the operator to get a sense for the trajectory of the needle. This is a dynamic process and relies on the operator's ability to detect tissue displacement created by needle movement. Staccato movements should be avoided. Needle position can also be inferred by observing the distribution of small test injections and making needle adjustments. Often, slight tilting of the probe can be used to locate and follow the advancing needle tip. In-plane needle manipulation offers its own set of challenges. Here is a sonogram of a block needle with the transducer sliding in and out of alignment with the needle. Subtle movements of the needle or transducer can produce marked changes in visibility. This pair of sonograms shows the same needle at different angles in a water tank. The needle is much better resolved when it is inserted at a shallow angle relative to the transducer. The next set of problems occurs when the needle trajectory strays from the plane of imaging. If the needle crosses the plane of imaging, but does not completely lie within it, only a portion of the needle will be seen. This can give a false impression of needle depth that can lead to complications. Alignment issues can often be addressed by leaving the needle stationary and manipulating the transducer until the tip of the needle is imaged. The needle bevel has a characteristic stair-step appearance that should be sought out.
So those are just important tips there that you want to be familiar with on there, and get familiar with the in-plane and out-of-plane techniques on that. Most of your injections are going to be done in plane. And if you're a beginner, it's really important to take some time and do a wet lab with this, which we'll try to do with our fellows each year in the beginning, and work with on your skills with needle visualization as well as needle positioning on that. But the in-plane long axis is the most precise, allowing you full visualization of the needle and shaft along the entire path, and gives us the best evidence for most injections on that. So in general, we want to use this technique and save the transverse for certain other types of injections on there. So always remember, put the needle in parallel to the probe on that, anchor your hand, choose the appropriate needle, and know when to withdraw and redirect on there. There's 3 different things that you really want to focus on every time you put a needle in. One is you want to think about the body, using the body's curves, so the needle is always going to be as parallel. 2, you want to think about your needle point entry. And 3, you want to think about whether you need to have any standoff gel pad. These all things help us in getting the needle as parallel as we want. So you can see here with this example, using the curve of the body to bring the needle directly parallel is better. This isn't as good here because of the steep angle, while this we're directly parallel. So always use the body's curve, particularly on the knee or hip, so you become in parallel. It will enhance your needle visualization on that. So you want to think about these ahead of time and use the body to your effect and move the patient in the appropriate position on that. So again, use the curved surface again, instead of trying to come in and get parallel underneath it. Use the body's curved surface so you can easily come in and stay parallel with it on that. The second thing is the entry site. You want to determine your entry site so you can stay parallel. So the deeper the structure, usually you're going to start further away from the probe. Starting further away allows you then to see more of the needle coming in under the probe and to be less steep going down to the target on that. So deeper targets always require entry site further from the transducer on that. There are some techniques using steering on the devices that can help get away with this, but it's always a good technique to consider your entry point on there. And then many times I calculate exactly what we're doing with the needle length as well as the entry point ahead of time. And you can use math on this to do this as you're doing it, and calculate the exact distance as well as the angle you need to on. Most of the time people eyeball this to get more experience, but it's a good exercise to go through and review your math principles on this, on how deep it is and what angle you're going to come at to be parallel with it. And this can be used for a lot of different targets, but again, most of the time we're eyeballing it, but this helps us determine exactly what length from the probe we want to come in and how deep we want to get to best visualize the area. And there's all different ways to do this in looking at needle length, et cetera, that we want to consider on it. So again, don't come close to the probe, use the curve, determine your point of entry, always trying to stay parallel to your probe on that. Remember, on curved probes, the beam fans out on that. So you don't want to come very close to the probe. You want to start away from the probe or tilt the probe because of the way the beam forms. So either heel toe or rock towards the needle, as indicated on this type of picture on that. The last thing about coming parallel is consider using a standoff pad of gel and then going through the gel. As you can see here, we're coming through the gel and we get better needle visualizations than if we were flat on the probe here. So you want to use the gel pad to help you come with your needle parallel on that. Another good tip on doing these injections is to really have solid anchors of your hand down. Your hand should never move. So you can see this is poor beginner error. Always have good solid anchor position on this. Choose the appropriate needle is important, and size can matter, particularly with more challenging injections. So think about that and think about fooling around with some of the echogenic needles. You can see on these deeper structures and some of these more obese patients can be more challenging, and an echogenic needle can help you, particularly if you're on a lower end machine that may not have good needle guidance things. And remember, constantly reassess. If you have a poor angle, it's best to pull out and restart, and don't make the situation worse on that. And really and try to do a pre-injection of anesthetic to make sure you have a good angle before you go in with your final solution on that. This allows non-painful redirects on this. If you don't see the needle, make sure you move you do the following: move your probe slightly at first on the x-axis, then align parallel by doing either a heel toe on the y-axis, and then last but not least, check your obliquity on the z-axis. And this is a good thing to do in the lab, and never move your probe and needle at the same time on that. Using some movements can be helpful, as noted in that video, to find your needle, and using some fluid in there. So don't hesitate to use small movements to see it if you're struggling on that, but they should be very tiny movements, and use fluid, particularly lidocaine, early on, so you can get anesthesia and also help find your needle on that. I'm not going to go into the out of plane at this stage, but when we do a lab on this, this can be good to practice on. It's a little more advanced on that, but it works very well for small joints that are very superficial on this. But remember, you're just seeing the tip of the needle, so this can be a bit more challenging on that. And we're going to save that for another time. But the important thing, if you're doing out of plane, is think about a walk down technique. So kind of come in superficial, find your needle, then walk down to the next level, and to the next level till you're finally at your target on that. This is the best technique to do, particularly with deeper structures. It requires some practice for beginners to work on that. So usually we like to have our fellows work with a phantom here and practice bringing the needle in and then walking down gradually on there. So it's a good idea. If you don't have a phantom, you can make one up and practice just the tip of doing a walk down technique like you see here, coming in at the different levels. As you come in here, working your way down, all the way down by changing the angle. Note the steepness of the angle to go all the way down on that, that you have to do to reach the bottom of your target on that. So it's important to start a bit away from the probe so you understand these mechanics on that. There's different ways to estimate that, as we talked about with math, and it's the same things apply on that. So we're going to kind of wrap this up by really emphasizing a few things. Always do a pre-injection scan, identify your target, identify the path, identify any undesirables, mark the probe that you want to go. demonstrate your target structure on that, then identify all the risks. Is there any vessels or anything around that you need to avoid on there? And then determine your final path of entry on that. Remember, you're responsible for all the structures in there. Make sure in the screen, make sure you understand everything that's in your screen. If you don't, really reconsider what you're doing and make sure you understand things doing ultrasound guided injections on that. Last but not least, it's important that you document appropriately on this. Indicate in your documentation why you did it ultrasound guided on that. We went over that. Use standard documentation on that, and we'll go over some more details of that at another time. And then document your aftercare instructions on that. It's important that you save standardized pictures. Usually a video clip of the needle at the target is helpful, but a pre-scan of the area and then a picture with the needle and a post-scan is pretty standard to do and to have in for your system. So 3 pictures or 1 video of the needle going in and then out, it can be helpful as well on that. And there's some recommended documentation guidelines that we discussed prior of this. We won't review other things at this stage, and I can't emphasize enough that this is really about practice on that. So last, there's a future article coming out. It's going to go over the different terminology put out by AMSSM and other societies, and I recently reviewed that as part of the AIUM, and that's going to be a nice addition. When it comes out, I'll remind you to read that. It's a nice consensus statement, and that should be coming out in the next month or 2. I'm going to just spend the last minute by turning it over to Tom and looking at the poll and answer any questions that may have popped up on that.
Yeah, I need to get off to see patients. I will make a gratuitous plug for, I'm giving a lecture on diabetes and the athlete for AMSSM Wednesday at 8:30, next Wednesday at 8:30. And recommend everybody attend, of course, because I'm giving the lecture.
Well, thanks everyone for joining us. I saw some of the poll numbers there. And a lot of you haven't done a wet lab. It's important that you either get a phantom and try these things out or pick up a pork shoulder. I think it's very helpful on the technique. So think about doing that with your faculty. Phantoms are easy to make, or you can buy them. They're pretty expensive, but they're easy to make. The easiest thing is buy a pork shoulder or a turkey and do that. And if you haven't done a cadaver course, a good idea to do before the end of your fellowship. Very, very helpful in learning to practice on there with some proctoring on that. And I think that about covers it on today on that. Tom, any other questions? I know we got to run on that, but we appreciate having everyone on board, and please give us feedback on this. I'll link to a few articles in another email and hope to get a little more consistent with these going forward. But thanks again, everyone, and have a good week.